Hi everybody. So right off the bat, I thought I was talking to new orientees, so I'm talking to experienced ER nurses. But just to let you know, I'm Nancy. I've been in the OB department for 30 years. So I know a lot, but I'm still learning every day, and things are changing every day with medicine, as you know. That it's very hard to keep up, and you're already asking me some questions on things that I don't know that are totally defined between our two units. But in particular, you can email me and I'll try to find stuff. I know between charge nurses and waiting for them to give us information sometimes is really hard because everybody is just so crazy in the hospital. But what I thought I was doing was an emergency care kind of PowerPoint today, but we can go into lots of questions if you do have them. I do have a couple objectives that are kind of boring, but they say you have to have objectives for your class, so that's kind of my objectives and goals for the day. I'd like to give a little bit of adaptions to pregnancy because I know you do take care of pregnant people in the hospital. Something that's really interesting to note is that blood volume actually increases by sometimes 1,500 cc's. Now it's not equal between plasma and red blood cells. A lot of it is actually plasma that increases more than red blood cells, and that's why when pregnant women come in and they always have anemia, and that's because of that issue. But I bet you can guess why she has an increase in blood volume, and that's to support the pregnancy, because almost 500 to 1,000 cc's are always in that unit, that maternal fetal unit, especially once you get closer to delivery. And because of this extra blood volume, her hemoglobin actually decreases and her hematocrit normally decreases. So if you see any blood work on a pregnant woman, that's why this happens physiologically. Another crazy thing is her clotting factors increase. That's why DVTs and embolisms are so high prevalent with pregnant ladies. And then what do you always tell a pregnant woman when they're tired? Oh, go rest. When you get complications of pregnancy, go rest, go lay down. And that's one of the worst things we do for pregnant ladies is put them in bed and don't let them do a lot. And then the other thing that happens is their vessels get leaky. They actually have vascular resistance that decreases, and that's why edema is so prevalent, especially in the legs, because you're up, you're standing, the vessels are leaking, so guess where they go. And then when we get upstairs, we have ladies in bed all the time, so guess where the edema goes? In their booty area, and it's real normal. But when you're thinking about emergency procedures, like intubation on pregnant women, think about their thick necks, because they also have swollen in that area. And IVs can be a little bit more tricky and difficult because, again, we're all swollen everywhere else. Now, there's a falsehood out there that says edema is related to preeclampsia, and they have totally booted that out of the literature. Edema is edema because edema is followed pregnancy. It is not with or just because you have preeclampsia. Now, it is common to have preeclampsia and edema, but edema alone doesn't put that red flag in, oh my God, she's got preeclampsia. Okay, so I like to put that out there. So things are happening with her heart because she's got all that blood volume and she's got another person inside her. Her cardiac output increases, her stroke volume increases, her heart rate increases, and because all that's going on, her blood pressure actually is supposed to decrease. And it actually is supposed to decrease about the 16th week until about 20 weeks, and then it's supposed to come up to normal. And we all know a normal blood pressure is less than 120/80. If that blood pressure doesn't bottom out, then that's how we kind of can tell when she's 20 weeks that she actually had chronic hypertension versus preeclampsia, because that blood pressure didn't drop somewhere in the 16 to 20 week time frame. But now we're getting women with ungodly blood pressures, and as you probably are getting it in adults in general, this is rampant to have high blood pressure in people these days, and it's very bad for pregnant women because not only she's got high blood pressure, but she's not perfusing her baby and her placenta, so it affects the whole pregnancy situation. And something crazy that you really don't see unless you're looking at an ultrasound or an x-ray, but her heart, when she's really close to the end of her pregnancy, that's creating this being, and this being is growing bigger and bigger. It's going to grow and it's going to fill up her whole abdominal cavity, and then it's going to push up into her ribs, which means her diaphragm's squished. It's eventually going to create some pressure on her lungs, so she can't take as deep breaths. She's going to have to breathe a little bit faster, so it messes up a little bit of her pulmonary system in that it creates a little bit of alkalosis. Or if you're doing gases on a pregnant woman and she's 36 weeks, just know if she's a slight bit alkalotic, it could be normal for her. Does that make sense? And then of course the wonderful hormones of pregnancy slows the gastric down, it slows her emptying time, and creates a problem where they have heartburn and indigestion. But if you're thinking about that kind of stuff and she's not digesting food like she could, if she comes in from a car accident, she just came back from eating, she's gonna vomit or she's gonna aspirate, because that food, even if she ate it an hour or two ago, it could still be sitting in her stomach because it doesn't digest as well when you're pregnant. And then again, with your GI changes is that upper airway edema, and then it increases the bleeding tendencies in the neck too, so there could be a lot of friability in the back of the throat during ventilations. Obviously, the uterus is the biggest organ that changes. What I want to present with this slide is the umbilical artery is running underneath the baby, as you can see in that picture. So if mom is laying on her back, she's not perfusing her body and she's not perfusing the baby's body. So if you ever have somebody, especially after 20 weeks gestation, please at least put a bump roll, a towel, a pillow, just something so she's not laying flat on her back. It's very important for her perfusion, but also the baby's. And you know, when you're taking care of moms, of course, mom has to be first. So take care of her, you know, as you need to. But if you can think about the baby in particular, that it needs to be tilted just aside to help her maintain perfusion to that baby. And if you think about that blood supply is 500 to 600 mils per minute that's going through that system. So if she's got an abruption, which we'll talk about later, she can bleed out really fast. So anytime after 20 weeks, or especially after 37 weeks, have her tilted, please. Women come in all the time, right? I didn't know I was pregnant, I don't know how far along I am. What you can easily do is get a tape measure. Do you have any tape measures downstairs? Or okay, all you have to do is measure from the bone of the symphysis up to the fundus, the hardest part of her belly. And for the most part, unless she's, you know, 500 pounds, which is speaking lightly, unless she is got twins or polyhydramnios or something crazy going on, for the most part, if she's 25 weeks gestation, she's going to be about 25 centimeters. 36 centimeters is 36 weeks. The only crazy thing is at 40 weeks, the baby tends to drop in the pelvis. So full term tends to be anywhere from 38 to 39 weeks, but that's really normal. And that's just an easy way to figure out gestation if she has no clue whatsoever, or she comes in unconscious. And I bet you could say the biggest reason you have people come in is because they're having contractions. So, and I know that totally is out of your comfort zone, but I just want you to relax just a little bit and I'll give you some clues. Contractions, I don't know if anybody's had a baby, they are rhythmic, they're constant, they're continuous. You don't need a clock. If you are having a contraction, typically, and they're really good active contractions, they're 3 minutes, and you can tell by watching your clock. Every 3 minutes you're going to have a contraction. If they're 2, they're 5, they're 7, they're 3, they're 9, and they're here and there, they're probably not good contractions. They're not dilating your cervix, so you don't have to come so fast. You know what I'm saying? I know you want to run as fast as you can, but you can take your time a little bit. Another thing is there might be some bloody showing that's pretty normal. The cervix is down there shifting, it's moving, it's dilating. So if she wiped, that's usually some of the questions. You know, tell me about your blood just a little bit. If she just wipes and it's a smear or a couple drops on the panty or tissue or something like that, it's not a big deal. Every woman can have a little spotting, especially if they just had intercourse or they're close to their due date or they're having mild contractions. The bleeding that you want to go past go, run the red lights, is the bleeding that's actually free flowing. You don't even have to think about it. You see her obviously bleeding. She's filling up period pads. It's more than a menstrual period. That's the bleeding that we've got to get her up to the unit because she probably has a severe abruption or previa and we got to get her to the OR fast. Typically, if it's her first baby and she says she's been contracting 15 minutes, most first baby labors are anywhere from 12 to 24 hours. So again, if you can't have somebody right that minute, it's not an emergency, okay? On the other hand, if it's her third or fourth baby and she's been contracting for 3 or 4 hours, that might be a little bit more significant because third and fourth babies tend to come in about 5 to 6 hours. You know, some take 10 or 12 hours. Everybody's a little bit different. But first babies, usually, now I won't say people on drugs and cocaine and things like that, they do kind of mess up the timing of things, but there's a little bit of difference between first babies and second babies. So that's another really good question that is one of our first ones when people come in the door. And again, the vaginal bleeding is something, and I just want to go into that in a little bit more detail. When I ask about, tell me about your bleeding, I also say, show, you know, what does it look like? as you know, bright red frank bleeding is obviously right now it's happening, and it's a little bit more paying attention to than something that's old and dark and may have clots. And it's not black and white, but it can tell you a little bit about what the cause might be. Pain involved is another one, because when we think about the 3 reasons for bleeding, abruption is the uterus has the placenta on the inside, right? And the placenta tears apart. Think of a torn muscle and how painful those are. So those are going to be painful kind of bleeding, and a lot of times they turn people into active labor. But if it's the placenta previa, which I'll show in a later picture, that tends to not be as painful because it's down by the cervix and it's just coming off the cervix. And the cervix on the inside doesn't have a lot of nerve endings, so it's usually pain-free bleeding. And then the other reason some people bleed is imminent delivery. Some could be bleeding just because they're early labor and they're having the bloody show. But some people that are getting close to labor, that might be the first indication that I see any blood is when they're 8-9 centimeters. So I always like to ask those kind of questions. So here's a picture of an abruption. As you can see, the uterus is firmly attached to the upper part of the fundus. Again, it's usually kind of dark bleeding that comes out. Sometimes it's pretty clotty, sometimes it's quite painful, sometimes there's contractions. And one of the biggest reasons, I have to add drugs in there now, but motor vehicle accidents, spousal or family abuse situations. Women do fall, but I don't see too many abruptions from falling. But now again, I should need to add illicit drug use, because crack and cocaine and meth, those things can cause abruptions too. Now I have had a few people that there's no reason whatsoever that they had an abruption. They just came in and we had to run to the OR, never could figure out why. So I don't want to say everybody that has an abruption has these things going on, but that's, if you had a patient come in with those reasons, that would be one of the first things I would rule out and check out, is does she have an abruption? And unfortunately, a lot of people think you can just send them to ultrasound and have an ultrasound. Ultrasounds cannot diagnose a placenta abruption. If it's there and it's a really bad one and there's a lot of clotting going on, they can see it, but you really can't see fluid in an ultrasound, right? So they may not pick them all up unless it's a really bad one, and by then we usually know that anyway. But that's, something false. And if you think about that placenta that tears off 100%, remember I said 500 cc's. We had a full placenta break off in our triage, and by the time we got her into our OR, which is just 2 or 3 minutes, the baby had died and didn't make it through the C-section. So if it's 100%, try as we can do what we can, but unfortunately, we can't save everybody, and you guys are big ones to know that one. Placenta previa is where the placenta is attached, as you can see down by the cervix. It's more common as you have more and more children, more and more C-sections, that causes the placenta to grow down there instead of the top area. And as the cervix shifts and the uterus grows through the pregnancy, it just causes shifting in that placenta, and so little vessels tear off. And somewhere about 28 to 30 weeks, and then again 34 weeks, those are the major growth times of the uterus. And so those are common times for babies or the placentas to start bleeding at that point. And what do we do with the placenta previa? We cross our fingers, hope the baby's doing okay, and she'll stop bleeding in a little bit, and we can keep her pregnant until about 34 to 36 weeks. Sometimes we've kept them on the unit. When I knew we had her for 6 weeks just in bed, on bed rest, and trying to take it easy, that way if it started bleeding, we were just minutes to the OR kind of thing. We do try, if they were early and she's stable, send her home again, but usually she comes in through the ambulance the next time. But again, it's usually bright red and it's painless. And she usually knows she has a previa because you can see this easily on ultrasound. So usually it's diagnosed early in a pregnancy. Anybody seen a cord prolapse? I know we've had 1 or 2 come through the ER. It's when the water breaks and the umbilical cord that's just floating around that water just kind of drops down before the baby's head does. At my previous hospital, it was a level 1, a real small little dinky hospital. The patient called, or the husband called and said her water broke was hanging down. And so luckily it was a smart nurse, had the patient get on her hands and knees with her butt as high as she could, got her in the car that way somehow, and drove her to the hospital. And that nurse called the OR team. So they met her and had her right back to the OR and did fine. On the other time, I've heard stories where patients came in through the ER and the cord is dangling on the foot stirrups of the wheelchair and the baby was gone already. So I've heard lots of good stories and bad stories. If you have a cord prolapse, the only way we're going to save a baby is if she's in a deep knee chest position, because it prevents the baby's head pushing on the cord. That's the only perfusion that baby's got. If that cord's perfused, or cord is clamped and not perfusing, that baby's not going to make it. And who knows what happened before she got to your ER. Does that make sense? So get her deep knee chest. If the cord's hanging out, if we cover it, they say with saline and stuff, but honestly, who's going to take that time? You're going to get her up to us fast again. You know, or call us down and we can do the C-section down there maybe. You know, we've done that before too. But this is one person that you want to get IV bowling as fast as you can and get some oxygen on her as fast as you can, and you know, call us so we're ready. We can have the OR team in the OR when you bring her up. Okay? Yeah.
If for some reason mom is compromised to where you can't, are you able to just do it in the, like with your hand in the position that?
We have done that before, where the water broke and I can see the cord hanging out of her vagina. Yeah, in the labor room, we tilt her back into Nullberg, and I put my hand in her vagina and hold the baby's cord off, the head off the cord. Yes, I have done that, but most ER people are freaky about putting hands in vaginas, so that's why I say just to put her in deep knee chest and not freak y'all out so much. But that's what we would do. Yeah.
Okay.
Yeah.
If a mom were to come in like this, and I'm new to the ED, so
That's okay.
And they're in triage, then we're not like bringing them to the back, we're just taking them up to you, right? Or are we bringing them to the back and then taking them up to you?
I would call OB right away and say, I got a cord hanging out, you gonna come and get her, or you want me, I would do that, yeah.
It doesn't require an ED physician to see the patient or anything before we
I
come
wouldn't,
up or anything?
no, because
Okay.
you're wasting time. We're talking about baby might already be gone at that point.
Sure. Okay.
Or, you know, barely hanging on. And we're just gonna tell to meet us in the OBOR is probably what we're doing.
Okay.
Yeah, good questions. So again, and I do this talk for the paramedics. I've done a couple of these with paramedics. So I added this in for them, but also if you are helping to bring patients up and there's something really bad happening, say she's really bleeding, or that's really medical, isn't it, really bleeding? Or she's got a prolapsed cord or something like that. Obviously not flat on her back, because we talked about that. We want oxygen with tight face mask, rebreather, 100%, get it going, because you're not necessarily giving it to her, you're adding it extra for the baby, right? And IV, don't worry about how fast, get it in and bolus. We want 1,000 cc's in as fast as we can, especially if she's bleeding, because we've got to replace that volume. But if we're going to the OR, we're going to need an IV going as fast as we can. Make sense? So this is what I'm sure scares most of everybody down in the ER. It's the actual delivery. But if a mom is delivering this fast, she's going to do it all by herself anyway. And all you need to do is catch the time. Really, it's the best thing that you can do is hands off and don't touch anything. What you can do to help things is to get her to breathe, to calm down, to talk with you, even if she's yelling at you, because then she's not pushing and grunting so vigorously. I don't know if you've all had babies, or some of you had, I know you haven't had a baby, but you know, it's this uncontrollably, horribly big bowel movement that's just about ready to deliver, and you tell your body not to push it out. And it just doesn't happen. There's some point you cannot stop this from coming. But if you get her to take a breath, calm down, talk to you, at least every once in a while, it slows the process down a little bit. And then it slows the force of the delivery down a little bit, gives us time to get there. And it also helps to prevent maybe some tears, some tearing that she might have down there. So that's really, if baby's coming, it's coming, and not a lot you can do. But you know, some women, I don't know how many of y'all got those crazy women that come in and they're grunting and pushing and they get upstairs and they're not even in labor and they're closed. So I just wanted to show that picture. If it may be offensive to some, I apologize, but you're gonna see parts of the body coming out. You've got bulging perineum. There's some sort of perineal changes going on with those ladies. And in those cases, I would stay where you're at and call for us to come down.
You guys don't expect We're gonna have to do like half hours and stuff like that. You'll come
You're
down,
not
right?
trained.
Yeah, you will come down and help us.
You will,
Oh,
yeah.
yeah.
We
Yeah.
have
Yeah.
That, or hopefully we've got them delivered in the ambulance before. Done that twice.
Yeah, and we might ask you questions, was the baby breathing, was there firmness to their arms and things like that, so we can either make up or just say that it's unable to do baby delivered in the bus, you know, kind of thing. So again, assisting the delivery, you wanna try to get her under control as much as possible by talking, breathing, at least, you know, not grunting uncontrollably for long periods of time. If you can support the head, obviously it's just any gloves, they don't have to be sterile. Support the head a little bit. If you had time to kind of reach in the neck a little bit, see if there's a nuchal cord. Some cords you can actually ease out around the baby. Some cords you can at least loosen a little bit and the baby will deliver through. A tight, really tight nuchal cord can entrap the baby a little bit. I don't want to scare anybody, but it can be very difficult to deliver is why I like to say those kind of things. Because if you got this tight cord, then the baby can't come out, right? So if you can try to loosen it up a little bit, sometimes babies can go through it. It's not necessary that we use a bulb syringe anymore. They prefer the babies just to get their nose with a towel or blanket, anything. Just wipe the mouth and nose a little bit. You can even go with your finger in the mouth a little bit. If you did use a bulb syringe, they want you to use the alphabet, M first and then nose, mouth and nose, M and N. If you were needing to clean the suction, the mouth and nose out from mucus and stuff, sometimes the baby poops inside, meconium, have you heard of that?
Yeah.
That again, if you can clean that out just a little bit, because if the baby takes a big deep breath, it could get in the lungs a little, but if the baby's got meconium fluid, it probably already has some in that area, but those are just some things. And then really the biggest thing we want you to do is catch the time. You're gently easing the baby down and easing the baby up. This is a real slow delivery, so this wouldn't happen in the ER with a really quick delivery. We drive the baby just a little bit, and this is a very old picture, but really what we do is just kind of hold the baby level with the perineum and dry the baby off. We try not to cut the cord now for 30 to 60 seconds, so there's no panic with that anymore, where everybody was wanting to cut the cord really fast. Don't even need to worry about the cords anymore. Biggest thing we want you to catch is what time the baby was delivered so we can put it on the birth certificate. Oops. And then we want the baby to go skin to skin. And I think there's a picture later on. Some complications that could happen, and this is what I like to go over them just a little bit, is shoulder dystocia. And I brought a baby down just to help a little bit. But what happens is the head comes out and then it's entrapped a little bit with the pubic bone right up here. And the shoulder is preventing the baby from coming out. And the first instinct is for people to come up on the top part of the uterus and push that baby out. But all you're gonna do is prevent this shoulder, just jam that shoulder even more. So where this hand is actually on the suprapubic bone. You wanna find her pubics, the bone there, and come just back underneath it, and you can pop that shoulder underneath the pubic bone. And that's kind of what we're doing with suprapubic pressure. We're also getting her legs back as far as we can, because just like when I open my arms up, my shoulder, my clavicle, and everything opens up, if you get her legs really far apart as much as you can, that gives almost an inch more room for that baby to come through. Something else that you could do that's pretty easy is have mom just go on her hands and knees, because sometimes just that movement opens her legs up in the pelvis, changes the baby just a little bit, and rotates the baby to deliver. So it's suprapubic, right above the pubic bone, to push that shoulder out, get the legs back really good, or put her on hands and knees. Anybody seen a breech? I did this class to the OB girls one time, and we talked about how to do a breech delivery, and by golly, that night somebody came in to the ER and delivered a breech baby. So she had to run down and do that. So I hope I didn't jinx any of you. But obviously, in a breech, you've got the baby's backside coming out, and the problem with that is the head gets entrapped and the head doesn't want to come out. So the instinct is to start grabbing and pulling, right? Which is the absolute worst thing to do, because the head is trapped, the chin is trapped, you know, and it's just not gonna go anywhere, okay? So if you support the baby by putting your hands underneath and support the baby, and if you can get a finger in and bring the chin down, see how I'm doing that? I'm bringing the chin down a little bit by putting my finger in her vagina and grabbing the chin. That usually can ease the baby out, but you want to ease the baby out kind of vertical. Sometimes you have to twist and turn a little bit, but you don't want to just yank a baby because that can make the getting stuck even worse. Again, most babies that are coming out really fast in the ER are going to come out really fast in the ER, but I had to just give you a little bit of fun stuff to make your heart beat a little bit, right? So mom's delivered. Everybody's fine. She might be cramping now. She's going to be bleeding now because that uterus has a nice big open wound on the inside, and her uterus needs to clamp down, do that involution process to shut the blood off. Rubbing her belly will only make her cramp, but that's what you want. But what you want to do is, you know, in the rush of everything, and there's a million people in the ER, right? Kind of push everybody out, close the curtains, give her a little bit of privacy, and don't worry about that placenta. Let the placenta come out. If 2-3 minutes, whatever, and nobody's come down yet, it's okay to clamp the cord twice, you know, and then cut in between. And then the baby goes skin to skin with mom. But don't worry about the placenta. It'll either come out by itself or the doctor upstairs will take care of it. You know the placenta's coming because usually the delivery itself isn't very bloody, but once the placenta starts coming down, the cord will start lengthening and there'll be a gush of blood, and usually that's an indication that the placenta is about coming. And then she'll have this urge again to bear down. It's really brief and nothing as violent as having a delivery, but that's what happens.
Are we cutting cords or
After
waiting
about a
on
minute or
that?
so.
What's that?
After a minute or so, you can cut the cord.
Okay.
Yep. And we like at least an inch or two from the baby to clamp and then cut beyond that. We want to give a little bit of a cord there. So what we're doing upstairs is we're actually either weighing or visualizing the blood loss. We have under butt drapes that have a cylinder that we can actually see how much bleeding she has after delivery. I know you don't have those down there, and I wouldn't expect you to have those down there, but if she's bleeding quite a bit, just something to think about. We like to weigh, or we're instructed to weigh from our governing branches now, because when you weigh blood, 1 gram of blood equals 1 cc of fluid. So if we weigh 500 cc's of fluid, it equals, 500 grams of fluid, it actually is 500 cc's. It's 1-to-1 ratio. So we have found in statistics, not me, Yale part, it's the whole world, that people tend to underestimate blood loss, and they're finding that if you actually weigh it, you get a better, approximation of how much you really lose. So I don't expect you to have a scale in your rooms when you have a pre-op delivery, but if it's a whole lot of hemorrhaging going on, we might save things and weigh it later. I can't say what would happen that day, but just a thought. So after the baby is delivered, like I said, it goes on mom's chest, and that's, it goes vertical, okay, head to the side, straight up and down. We're starting to find babies that have, it's called postnatal collapse, but they get down and they get smothered in the boob or blanket, and then they get, they don't breathe, their head's cut off, or their neck is whopper jawed, or something. So we're finding that this is the proper way. Baby should be right here next to the chest with the head to the side. That's the proper way for baby to go. And then, dry the baby, stimulate the baby, should be crying, wiggle the feet. We're tapping the toes pretty well. And then nice warm blankets over the babies. And mom should be skin to skin. Last preset I ran downstairs for, they actually cut her bra off. You don't need to do that, just flop it up. Okay, and then put the baby skin to skin. And nice and warm blankets underneath. It's nice to make sure the baby's pink. It's okay if the hands and the feet are blue, but the mouth should be okay. The baby should be breathing kind of normally, shouldn't be gasping. The chest shouldn't be sunken. She shouldn't be using these respiratory extra muscles down here to breathe. And if baby's doing fine, if you have time for temp, and we haven't come yet, a temp is great under the armpit. That just goes to show, especially if they delivered outside and you now are taking care of mom and baby, just to see how cold it is. That way to definitely get warm blankets if possible if the baby's really cold. 98 is a normal temperature for babies too, okay? So if the baby's not doing well, and I know you don't have a lot of the supplies, but we would begin chest compressions if the heart rate was less than 60. And you've done the positive PPV, the mask. Baby's not breathing, you start with the mask and then you wait 60 seconds and then do chest compressions. And slowly increase oxygen. We don't want to give baby a lot of oxygen right at first. We're finding babies do really well on room air. All they need is just what we call it a jump start upstairs. Just the bag and mask to remind it to breathe, and most babies come around. But if baby's not coming around and you're actually doing the PPV mask and you're actually doing chest compressions, then you do want to give oxygen. And by golly, the nursery nurses better be down by that point. But again, 60 is when we would stop doing chest compressions, and then we would do PPV until the heart rate is over 100. Preemie babies. I don't know if anybody's seen any preemie babies that have come in that have just born, but obviously they're very tiny, their skin is very fragile. The biggest issue for these babies besides respiratory status is they're going to be extremely cold. And that's why I wanted to show this picture. What we do is not only at this point, because we're working on the baby, we're not really going to be doing skin to skin because this baby's going to need help breathing and may need chest compressions, probably needs an IV and all, but this baby needs to be warm. And so if you have anything plastic downstairs, even a trash bag, put over the baby up to the neck, because that'll maintain the heat for the baby, and then put warm blankets over the baby or even under the baby before you heat the baby down. But we want to keep those babies nice and toasty, and it sounds funny, but you can actually get a big Ziploc bag we've used and put the baby in a Ziploc bag and just kept the head out, obviously. Preemie babies like this, obviously you gotta be gentle, but you don't wanna put their head down because it just encourages the blood supply to go to the head, and then it can have some brain bleeds. So these babies you want to try to keep as flat as much as possible, and then avoid excess pressure. So if you got that teeny little lungs, you want to do just really small little breaths if you are doing ventilations on those babies. And I just put this up here just so you can see what's going on. We're going to dry and stimulate, remove the wet stuff. I don't think you would have oximeters for babies, but they go on the baby's right wrist and give oxygen. And then as you can see, we don't expect until they're 10 minutes old to actually have a biox of anywhere from 85 to 95. And that's why we start out really low with oxygen, because babies are normal at 60 to 60 at 1 minute. That's just really normal for newborns.
So do you guys do the bag, or do you wait 10 minutes to see what it's looking like?
Nope, we start it right away. If baby's not breathing,
Okay.
we start doing our shifting, wake the baby up, stimulate, dry the baby off, assess the baby again. If it's not breathing, we jump right into PPV. Then again, we PPV for 30 minutes, then we check the heart rate. But what I'm saying is oxygen, we don't have to start oxygen until these minutes here.
Okay.
But you're not gonna have a scale downstairs. But I just wanted you to see, so you don't panic. This is why we don't do oxygen, because this is what they found to be normals. So this is where I go into the hypertensive and the complications, more of postpartum stuff. And I'm not gonna say that anything like this happened in our ER, but this happened somewhere in Georgia. I was doing some research on this, and this is the story from USA Today that Yolanda gave birth. She was 38 weeks and it was her third baby, and she had chronic hypertension during pregnancy and she was on medications. She delivered, didn't have any problems, but her last blood pressure taken before she left was 175/94. So right there I blame the OB unit, because we should never have sent her home at that point. Later in the day she started getting a headache once she was home, and it got worse once she was at home at night, and she kept blowing things off little by little. Finally her husband encouraged her to come to the ER, and that was their first blood pressure that they took. And she was describing her headache as 9 out of 10. So this kind of goes to that topic we were talking about with headaches.
Yeah.
She did go for a brain scan, and then waited 3 hours for the results and the ER doctor to talk to her. She was still sitting in the waiting area at 352, hadn't seen a doctor yet, and somebody did a blood pressure and it was 216/104, and her headache was even worse. So her doctor, or her husband, went to the whoever, I don't know, they described him knocking on the window and saying, hey, we really need to be seen by a doctor or a nurse. So as they finally put her in a room, but she had her stroke in the patient room in the ER. Unfortunately, now that I've seen this, I keep hearing more and more stories. You can type out maternal deaths. I am appalled. I just used it as my capstone for my master's project, and I am just appalled at the amount of moms that are dying. And these aren't things that are natural and normal. These are things that we as hospitals could be doing a better job of. And I'm blaming right at the beginning that the OB shouldn't send people home like this, and they need to be teaching moms better. So I'm putting the first blame right on us. So there's some question in the United States about mortality rate. Some do mortality rates up to 6 weeks after delivery, and some are doing the whole entire year after delivery. So right now, we're not communicating well as the United States is defining mortality rate. So as more and more states all jump on the same bandwagon, we're finding out now how bad it is, because before we never communicated. And in fact, last year was Indiana's first year to be part of the Indiana Mortality Review Committee. So the state of Indiana is pokey slow getting going on this stuff. But according to this definition, was within 42 days of birth or the end of pregnancy, could be a miscarriage or something like that, I guess is why they say in that. And just as a stat, over half of all mommies are dying within 42 days. So that tends to be a really good time frame to grab. But again, some states are using 1 whole year. According to the CDC, 60% of all maternal deaths are something that somebody could have done different. The patient could have said something, and she was poo-pooing her symptoms. The nurses didn't teach her right. The nurses missed. The ER didn't do something. Something. We're doing something wrong in the United States that we could fix. Here's a picture. It's not just United States, but unfortunately, United States is number 1 of the developed countries. It's kind of sad to know that. And you know what's even worse? If you looked at the state of Indiana, we're number 3. And that's not the good, that's the bad. There's only 2 other states that have a higher maternal death rate. Does that make sense? If you found this, USA Today, her name is Allison Young. I had a really hard time finding this except for hers. But if you click on the state of Indiana or any state in the nation, it'll tell you their statistics as of 2016 or 17 kind of thing. But it's not good. We've got a lot to do in the state of Indiana. Top causes. In our area, it's hemorrhage. A lot of other areas, it's cardiovascular disease. So you take your pick, who's obese and has chronic hypertension, or is it a mom that's had 5 or 6 kids? She's going to have a higher risk of bleeding. So there's preeclampsia, which I throw into cardiovascular disease, thrombosis, amniotic fluid embolism, which is nothing we really can do to save that mom, except get her to the OR and get her on a life support. But infection, that's something that kind of surprised me that it's in there. We don't see too many postpartum infections that are that bad, but it's just something interesting to note that you got somebody come in, she's 2 or 3 days postpartum, and she's got a really high fever, or she's septic, she easily could die from that.
I have a question.
Yeah.
I had that
Did
last
ya?
weekend, and she had a fever. She just gave birth 2 days ago. She had headache, fever. I asked if she had any other symptoms. She said no. I called, and they said just to keep her down
Mm.
In the department.
in the department. And I was like,
We
okay.
ended up sending her up though.
Did you guys?
Yeah,
Okay.
Dr. Bruce.
Yeah, it's hard to say. It just
Yeah.
depends on what doctor's on and what they want to do. Sometimes we leave people in the ER because you can get things done faster than we can. You have ultrasound, you have lab, you have the ability to get things. If we put them up on our unit, it takes forever to have an EKG or a chest x-ray done and things like that. So there is that thought process, just to let you know. But there's also some doctors, maybe the doctor was in the OR all day long and couldn't see her for hours on end, and at least you got a doctor to see yours. So there's lots of thought processes that change from day to day and minute by minute. Of course, we just had a patient seize upstairs before I came down here. We didn't have a doctor on the floor. She was in the OR. So we luckily called, the doctor from the office to come up and see her so we can at least get some treatment going. So every day is different, just like every day is different for you guys. So there's some called early warning signs, maternal early warning signs. Some people call it mews, some people call it meows. There's different lingos for it, and I guess Memorial and us, we haven't combined our lingo for this yet. And supposedly you guys had this talk about a year ago about early warning signs. So just to refresh, the stuff on the right-hand side in black, you want to kind of confirm. If your blood pressure is high, I was taught 30, 40 years ago how to take a blood pressure. Did you know you're actually supposed to sit for 5 minutes in a sitting position, not talk, and have the blood pressure cuff on the upper part of your arm with the right size cuff and your arm actually supported? I totally forgot about all that stuff when I started doing all this. You know, how do I take her? I lay her down, I lay her flat on her back, she's all tense, she's nervous, and I do a blood pressure right off the bat when she walks in the door. And that's actually the wrong way. So we really need to evaluate, is this really the best place, the best cuff? How many of these women don't fit blood pressure cuffs anymore either? You know, we've got all these complications. So, you know, take a few minutes, reassess the situation, and if your blood pressure is really high, then we need to start moving if we really know that that's the right blood pressure. The stuff in red is stuff that we need to do immediately, and we all know that people that aren't peeing usually have chronic or, you know, emergency kidney problems, agitation, confusion, you know, things like that. Those are all emergent stuff that we want to talk to the doctor right away, especially if they have any of the other vitals that are going on. So I already said hemorrhage is one of the most common causes of maternal death. The definition is a vaginal delivery of 500 cc's. Blood loss in a C-section, it can be 1,000 cc's. Now, something in our unit that I think we tend to forget is it's not just that bleeding here. You have to add the bleeding that she had during the delivery. So if she delivered 5 hours ago and 500 cc's at that point, and now it's 6 hours later and she does another 750, you got to add both of those volumes together for 1250. And so you need to treat her according to what blood loss at 1250 is. And we have all that stuff defined upstairs in a checklist. And then another thing is she's usually filling her peri-pad either continuously or very rapidly. And then of course, we don't visualize upstairs, we actually weigh the pads so that we can call the doctor and go, gee, you know, her temp's pretty high, her head was really hot when I touched it. Does that mean anything? But if you say I've got a mom and she's got 104.5 temperature, they're gonna take a little more bit of attention to you, right? Same thing with bleeding. If I go, well, she filled up a pad, it was pretty full, it might have drained on the floor a little bit, or if I say we just got 1,500 cc's out in the last 15 minutes, it makes a difference. And so that's why we're taught to do that by our governing branches for women's health. So what do? We replace the fluids. We have a special medicine called oxytocin, and there's some cousins that we can give in addition to that. We do fundal massage. We're rubbing that uterus, saying, hey, like that Annie, wake you up. You gotta get that uterus rubbed. And then you could breastfeed at the baby's close, because then that helps her to make her own oxytocin. There's a delayed hemorrhage, and that's what you're gonna see more times than not. She's anywhere from 6 days to 6 weeks after delivery. And a lot of times it's because a placental fragment was in the uterus that got missed and now it's popping out, or she's infected from that retained fragment. And this is my request is, I don't know, maybe you guys could be inventive and you know, start making these national magazines, but would you think about weighing pads if you got a postpartum hemorrhage in? Just a thought, so that, you know, she comes up to us or you're having to replace blood, now you know how much blood she lost, and so you can see right off the bat. So just a thought. Some of the, you know, I know it's kind of creepy to do that, but it's so much information that we can gather when you know how much blood she really did lose. And that's how we do it. We have a list of stuff upstairs that has the dry weights. So all we do is we take the dry weight and we subtract that from the weighed wet stuff, and so you know exactly. We had posters all over the place. We did this in the OBUR. The doctors still fuss with us about it because they still want to say what they want to say. But you know, they don't like us to say you had a little bit more bleeding than you thought you did, you know, kind of stuff. So you'll still see op reports that differ from what we say when we weigh it out, but it'll get there. Just something to think about. And this is the A1 management plan. A1 is our governing branch, and this is what they have. And they have different stages of hemorrhage. And so you see if you're at stage 2, which is 1,500 cc's, it says you need extra staff at bedside, you need to do vitals every 5 to 10 minutes, you need to weigh the blood, consider ISTAT, do a DIC panel, and then maybe consider going to the OR for DNC or something like that. We might even move to the OR and have the uterus removed, or have our arteries, licensed by radiology. There's lots of stuff, but each stage has its measures that you should be doing. So we use something similar to that upstairs. So the other thing that causes more women to die is something related to cardiovascular or severe hypertension. The definition now is greater than 160, or excuse me, I say that wrong, 160 or greater, or 110 or greater, twice. And again, check the blood pressure cuff, make sure you get the right cuff, the right position. Mom's relaxed just for about 5 minutes without talking. Check it again, and it says 2 blood pressures within 15 minutes that you know are accurate blood pressures. If she's not getting, better with the second one, the doctor should be called, because we have 1 hour, and I think it's facility-wide. I don't think it's just in the OB, it's facility-wide that she should have antihypertensive medications on board. Something that Anthem Scorecard and our Leapfrogs, they're all looking at that kind of stuff. Right now they're only auditing us, and so we actually have somebody that's auditing every chart that has a blood pressure greater than that. And then I have to go back and look at that chart to see what did the nurse and staff do, did they do the right things? And we're doing fairly good. But this is the stuff that we're working on upstairs. And so I think that's why we're introducing it again to you. This is the, not my thing, but I did kind of create it in the format that it is. This is ACOG, the Association of Gynecologists, the Dr. Branch. This is what they say to do, that there's 3 medications that we give for severe hypertension. You can do nifedipine, especially if you don't have an IV on board. So just give her a Precardia or nifedipine pill, and now you've met your 1 hour time frame. The docs will, if there's an IV, give labetal IV push or hydralazine IV push. But then there's your blood pressure measurements on how fast that you really should be given, reassessing these patients with these medications. And labetalol in particular, pharmacy wants us to have EKG leads and cardiac monitoring. And if the patient is pregnant with this stuff, the baby should be on fetal monitors, because if you're lowering mom's blood pressure, you're lowering fetal blood pressure, and it could actually do fetal compromise on its system. There's also directions there if she had a seizure, and what we would do for that, mag sulfate and such. And so we did earlier today.
So you would be coming down for the fetal monitoring when we're giving the little labetalol, is that correct?
Well, I would hope that we would be joining her upstairs, because we would want her on continuous monitoring. But if you had to start her to at least get her, meds started, you could be pushing it while you're walking to the upstairs to the OB unit, is what I would hope.
Okay.
If she's delivered, then, we wouldn't have to worry about that. But I'm still thinking if she's got severe hypertension, especially if it turns into preeclampsia, she's going to eventually be sent up to our unit either way, because I think that's what they're starting to do for the most part with all mommies, at least 6 weeks postpartum. Is that what I'm thinking? I didn't get to hear.
That's the information that I got.
Yeah, I didn't get to hear the definite things, but I think that's what we're starting to do. So the last thing I think I have on here is just thinking about CPR during pregnancy. I do know we've had one person that came in and needed to have CPR when she walked in the door. And she was pregnant, and we saved her. We were a great team that day. The idea is just to remember you have 2 patients. So obviously if you're doing CPR, get us down here, and I'll go into a little bit of some things you do differently with pregnant ladies. But there's the major reasons that you're going to be doing CPR, or the paramedics are doing CPR out on the field with those reasons. And some challenges that we have, we've already talked about the airway, because she's swollen, she's pregnant. It's a little bit harder to see the spots you have to go. It's harder to breathe because depending on where she's at in her pregnancy, you've got this huge belly, and you don't have the lungs, you don't have the chest compression as easy. You just can't see everything, and then if you've got her flat on her back, she's not perfusing. So no matter how good your chest compressions and resuscitation efforts are, if she's flat on her back, you're not gonna, be able to perfuse her whole body well. So there are some problems. So some of the things to do, a little bit to think about, is you might need to have a smaller ET tube because of the thicker throat. What we do is at least I've been the literature, because this isn't Elkhart General's rules, these are something I got out of literature, is it after 2 attempts just to go to an LMA. Cricoid pressure is something that we always use upstairs when we're giving our OB moms, if they're going for surgery for C-sections and they're going to give her a general anesthetic, we always give cricoid pressure. So I know that's been out, kind of scoped on most patients, but if they're having trouble intubating, that might be something to think about, is a little bit of cricoid pressure, because our anesthesia is always going to do that. And if you're ever doing an OB code, don't hesitate calling the OB CRNA because they're always in the house and they're experts at this stuff. You might have to increase just a little bit more with the PPV, and remember she's used to breathing a little bit faster than normal, so it's okay to go a little bit faster. Circulation is, the only thing you can do is just, get those chest compressions going. The older literature suggested to tilt mommy to the side a little bit, displace the uterus. As you can see, they're kind of somebody's pushing off to the side a little bit. You can't really get a bump under her back that well because then you can't do CPR right. It messes where her heart is and stuff. So you have to play it by ear. If you don't bring mom back to life, you're not going to bring baby back to life. So you got to do mom first, okay? If you've got plenty of people in the room, there's somebody doing the lungs, somebody doing chest compression, somebody doing everything else, you have one extra person, have her displace the uterus if there's room for that person to come in and do that. So that's only the extra person. Save mom, save baby, okay?
So by displacing uterus, you mean just kind of push it over?
Kind of, you can actually see how he's staying in his hand, or you can, if you depend on what side of the bed you're on, one's this way or one's this way.
So it doesn't matter which way?
No. To the left is preferable if you can. Is that what you're meaning?
Yeah.
On to the left side? Yeah, because that uterine artery is just a smidgen more to the right side. So if she's on her left, it helps it. But, you got to be able to do good CPR first before you worry about the other stuff. And that's new because I taught the paramedics, so if they come in, they might be doing that, but it's okay not to do the pushing the sideline anymore. And then I can't even say that word right now. Thank you. Go ahead and do it. Doesn't matter. You got to save mom again to save baby. So do your ACLS, run down the list, do whatever you can because, if you don't do what you got to do, baby's not going to make it either. And everybody's so worried about, saving the baby. You got to take care of mom first. I don't remember the next slide. So your medications, basically, they're all the same. IVN, wide open, your ACLS drugs. And I don't remember the medicine so well because it's been 1.5 years since my ACLS, but epi is preferred and amiodarone is preferred. And again, don't worry about mom or the baby, give what you got to give to save her. So here's a scary thought. If you see perimortem C-sections greater than 20 weeks, 4 to 5 minutes. So if she's at home and the bus is bringing her in, you probably have missed that time frame. But if she codes in the ER or the OB unit, we want to start that clock the moment we see the code start because we have 4 to 5 minutes to get that baby out. Now, I'm not saying that to save the baby because if you notice, I already said if they're less than 24 or 5 weeks, we're not going to save the baby anyway because those babies don't make it. But what you're doing this for is you're doing this to save the mom. Those are the only moms that have made it, is when they did a C-section, got the baby out, okay, all this blood supply going to baby, now goes back to mom. And if she's gonna make it, she'll do better after the C-section, because now her perfusion, now her body is gonna take care of her instead of that parasite that was taking all that blood and oxygen away from her. And it's gonna take care of that vena cava issue also. So get the baby out, you save mom, and hopefully you save the baby now, because now the nursery can be here to resuscitate the baby. So again, how do you know she's over 20 weeks? Grab a tape measure. Ask family how many weeks she is. And that is the recommendation over 20 weeks is the C-section. So was anybody here that day the dad dumps the mom off in the ER doorway? Were you here that day?
Oh, yeah.
Yeah, he wasn't breathing, dumped her off at the door. He took off and left a very pregnant mom in the ER waiting area.
No, the ambulance
In
bed.
the ambulance area, non-responsive, not breathing, they coded her, called us down. We did a C-section down there, saved them both. We did the C-section in the ER. All we need to do a C-section is a scalpel. So as long as you have a scalpel handy, that's all we need. She's not gonna feel it. She's not gonna bleed because her body's not perfusing. All we need is a scalpel and the nursery team to take care of baby. And then once the baby's out, they save the mom. Okay? And they both made it. Actually, baby did a lot better than mom did. I think she took a little while. And what it was is a huge thyroid, wasn't it?
They transferred her down to in
Yeah.
this part.
Huge thyroid that was blocking her
Anyway,
airway, and she couldn't breathe, and it just.
They ever fight and prosecute
I
dad?
know.
He eventually came back.
You're kidding me. Where did he go?
I don't know. I think he
gas
panicked.
station. We had to call the police.
Okay, I missed that part. So it does happen,
Wow.
okay?
And
I
the
just,
worker in
no,
the
that's
back
why I
of the
cover
car.
this stuff, because of the things that we've heard. We also had that wonderful time that we had the saddle block,
Yes.
and that was, were you heard that day too?
Yes.
Oh my gosh.
Don't work with Kate.
I'm never gonna. But again, that was great teamwork. We
Yeah.
do great things together, and we
Yeah,
just
that
need to
was
keep
awesome.
that up. It's teamwork, it's conversation, it's